We're going to talk about inflammatory dermatoses today. A lot of this introductory information I want to go over comes out of Bernie Ackerman's book on inflammatory dermatoses. It's an algorithmic approach to sort of figuring these out. And I found it extremely helpful when I was training, as a dermatopathology fellow to sort of sort these out, because it's really all about superficial and deep inflammation and the types of inflammatory cells seen. And so this first slide that I have up here is taken from the book in the second edition in 1997. The first edition of Bernie Ackerman's book, called The Gold Book, came out in 1978, and it really did revolutionize pattern recognition for inflammatory dermatoses. He updated the book in 1997. They call that the Silver Book, and that's where these algorithms come from. And really, this book is invaluable for sort of differentiating, from every topic, from psoriasiform dermatitis to spongiatic dermatitis to paniculitis. But today we're going to talk about interface dermatitis. And so the way Dr. Ackerman sort of breaks it down is you start your pattern analysis obviously at 2x and or very low power with our new format of using slides that are online and scanned in, superficial and deep, and then from there you try to determine if it's an interface dermatitis and go from there. So this first slide is the superficial only pattern, and then we go to interface dermatitis. And so interface dermatitis is broken up into vacuolar and lichenoid. From there, we try to determine the inflammation. So are there lymphocytes only? Are there a mixture of lymphocytes, eosinophils and neutrophils? Are there histiocytes present? And sometimes there'll be plasma cells that can be very helpful in differentiating them. And so, and then on the right here, you can see the whole list of possibilities and specific histopathologic findings that help you differentiate between them. A lot of times on the board exam, you won't have a clinical image, because obviously with the clinical image, it will make it much easier to sort of differentiate, and they're going to want you to differentiate them based on the inflammatory pattern. Okay, the second slide here shows when it's superficial and deep, and then when it's superficial and deep, vacuolar versus lichenoid, and then you have a different list of inflammatory dermatoses that are superficial and deep. And there is some overlap. Some are superficial only, especially things like lupus can be superficial only and superficial and deep, depending on what subtype you have. Okay, and this third slide I wanted to show comes from this predates Elston's book when he was at Geisinger Medical Center. We had compiled some notes from his lectures prior to it coming out in book form, which it is now showing that you can break lichenoid and vacuolar on a different pattern, whether or not there's eosinophils, and he likes the term a lymphocyte in every hole for vacuolar interface dermatitis to sort of differentiate between the two. So you can also use this chart to sort of help differentiate. And I'll mention some of these things as we go through the slides. Okay, so let's start with the first case. All right, and again, we're going to use Bernie Ackerman's pattern recognition to sort of help sort through this. So at this low power here, we see that it's superficial only, but obviously when you're approaching an inflammatory case, you don't know if it's spongiatic, psoriasiform or psoriasiform or lichenoid or psoriasiform until you sort of get down to the nuts and bolts and get to higher power. And so here we have a band-like infiltrate that's superficial only, and then we start to notice some other findings. Usually what I try to do is go to higher power and look at the epidermis and see if I can find necrotic keratinocytes. And here we have them. You can see that these are also called dead reds because as the keratinocyte dies, so to speak, they leave sort of a pink outline left. And so we'll sort of scroll across the DEJ here, and we see that there are scattered necrotic keratinocytes. So we are dealing with an interface dermatitis. And so when we go back to lower power, we now know that it is an interface dermatitis, that it's lichenoid because we have a band-like infiltrate of inflammatory cells. And then based on the cell type we're going to do next, we can sort of help try to figure this out. So if we go to higher power, we can see that it's mostly lymphocytes. There are a few histiocytes. And I want you to note that there are also eosinophils. And this is important to know because what this is labeled as is lichen planus. But it turns out that you can have some eosinophils in lichen planus. And of course, a lot of it depends on the clinical. However, this also means this could be a lichenoid drug eruption because we have eosinophils. Typically, lichenoid drug eruption has parakeratosis and eosinophils, and that's a good way to differentiate lichen planus from lichenoid drug eruption. With any interface dermatitis, we get pigment dropout or melanophagens, so that's what all this dark material is. This is melanin pigment. So as the keratinocytes die, the melanin that's in the epidermis drops down into the dermis. One other thing I'd like to point out, a lot of times we try to figure out acute versus chronic interface dermatitis. And here we know it's chronic because we have something that's called squamatization of the basal layer. Another term for that is premature maturation of the basal layer. So normally there's 1 or 2 basal cells present, and then as we go from that to the spinous layer to the granular layer, we see maturation. But here maturation goes basically from top to bottom, and that's a form of chronicity, and that's seen in things like lichen planus, lichenoid drug eruption, and lupus erythematosus. Of course, if we had this clinical photo, then we know this is lichen planus, and oftentimes on tests of knowledge, we are not going to have a clinical photo. And so that's why we're focusing so much time on pattern recognition. So again, this on the slide set was labeled lichen planus, and with the clinical photo, lichen planus, but the presence of eosinophils, this could also likely be lichenoid drug eruption. This next case that you didn't have, I just wanted to show sort of as a correlate. And one other thing I didn't mention in the last case is there was wedge-shaped hypergranulosis, which you often see in lichen planus. This condition can look a lot like lichen planus in its early stages. However, in this case, we have pallor now, edema, and sclerosis of the upper epidermis. We still have, of the upper dermis, we still have pigmentary incontinence and that premature maturation of the epidermis. We even have wedge-shaped hypergranulosis. However, we see that since the pallor is there, this is lichen sclerosis, and an early lichen sclerosis can look just like a lichen planus. And so sometimes in the genital area, the early differential diagnosis is lichen planus versus early lichen sclerosis. Okay, so let's go to the next case. Okay, so with pattern recognition on the next case, we see that we have a superficial and deep perivascular infiltrate, and we still have the band-like infiltrate in the superficial dermis, but going off of Bernie Ackerman's algorithm, we know that this brings up a different set of conditions because it's superficial and deep versus superficial only. The next thing to do is to go and make sure that there's necrotic keratinocytes, the DEJ, to make sure it is an interface dermatitis, because this is also very psoriasiform because we have elongated reedy ridges. And so there's even, so I'm giving you a couple pattern recognition, but you can use other things too. There's even a differential diagnosis for psoriasiform lichenoid dermatitis, and there's some things you should take a look at there. But we know that this is an interface dermatitis because we see that there are necrotic keratinocytes or dead reds present here's another one in the epidermis. Okay, so let's look at the inflammatory component, and we see that it's mostly lymphocytes and histiocytes. And we know they're histiocytes because they're more elongated, pale nuclei, and there's abundant foamy cytoplasm around them. But there's also these more coal-colored or dark lymphocytes, and they're sort of intermingled. And in some areas in this one, this case, there are plasma cells. Let's see if I can find a plasma cell here. There aren't as many. We know that plasma cells have a pinwheel nucleus and a perinuclear HOF, where you have a lighter area as part of what a plasma cell is. Okay, so if we have psoriasiform lichenoid dermatitis, perivascular with lymphs and histiocytes and plasma cells, that should make us very concerned for a mimicker of a lichenoid dermatitis. It is a lichenoid dermatitis, but it's really an infection of secondary syphilis. One other feature that's important are these elongated spiky reedy ridges. That's very common in secondary syphilis. And also, you should get endothelial cell swelling. You sort of see thickening of the endothelial cells, and that's very common in secondary syphilis. Fortunately, these days, of course, you can get an RPR. You can call the dermatologist and ask him to order an RPR to confirm your concern. But now we do have an immunostain that's very helpful for treponemal pallidum. And so let me show you that on higher power. So these red spirochetes are present in the epidermis, and they can also be seen in the papillary dermis around those areas of endothelial swelling. So this is sort of, a lot of times now we'll just get the immunostain when we're concerned for secondary syphilis. Of course, if you have a photo, these are sort of the classic ham-colored papules that you see on palms and soles of patients with secondary syphilis. But again, on tests of knowledge, oftentimes we don't have the clinical photo, and so we have to sort of make the diagnosis. Let me just, again, from pattern recognition, the differential for psoriasiform lichenoid dermatitis also includes things like PLEVA, and which we'll go over, Mycosis fungoides. So these are things you should also be thinking about. However, when you see the ice pick reedy ridges, the mixture of lymphocytes and histiocytes and plasma cells, which I was hoping to find, but I still haven't found one, to show you as an example, that's secondary syphilis. Okay, so let's go to the next case. All right, so again, with our Bernie Ackerman pattern recognition, we have a superficial and deep perivascular infiltrate. And so that takes us to the second slide that I was talking about. All right, so again, we still don't know if this is an interface dermatitis or not, because superficial and deep can be seen in spongiotic and psoriasiform dermatitis. All right, so we go to higher power. All right, so the past two cases were more band-like infiltrates or lichenoid dermatitis. This one is more vacuolar, and so on higher power we see small little vacuoles, white spaces along the DEJ, the dermo-epidermal junction. And of course, Dr. Dirk Elston likes to use either lymph in every hole or not as many lymphs in every hole as an option. And it's kind of, it can be difficult, but at least brings up a differential diagnosis. The other interesting thing about this one is there's some extravasated erythrocytes. However, it turns out that ends up being a red herring on this case, and I'll talk about that. Again, this is superficial and deep, and we also have periacrine or periapocrine ecrine duct inflammation. So again, we go to lower power, it's superficial and deep, and we did find some necrotic keratinocytes, so we do know that this is a interface dermatitis. What's interesting about this one is there's also spongiotic dermatitis, and the way we know that is we see sort of spaces between the keratinocytes. You can see the keratin bridges more, between keratinocytes when we have spongiosis. There's a necrotic keratinocyte there. So superficial and deep, perivascular, interface dermatitis with spongiosis with periacrine involvement. This is lichen striatus. Of course, it's helpful when you get a clinical and you find out that it's a child and you have a linear eruption. Then you know it's lichen striatus. Other things to consider with this is lupus, because you get periacrine inflammation with lupus. But again, but lupus should have other things like interstitial mucin, basement membrane thickening, and we're not seeing that. The extravasated erythrocytes might have been a confusing thing. You might, oh, this is a pigmented purpuric dermatosis, because normally you see extravasated erythrocytes in PLEVA, Gougeron bloom type of pigmented, lichenoid pigmented purpuric dermatosis, and even in Pityriasis rosea, but Pityriasis rosea, of course, is a spongiotic dermatitis. So again, I think the key features are superficial and deep, perivascular, with interface dermatitis and spongiosis and periacrine inflammation. Of course, in the clinical with a linear eruption in a child, you have lichen striatus. All right, let's move on to the next case. Okay. So again, it's kind of becoming Groundhog Day. We want to use the same pattern analysis each time. You don't make a mistake. So again, we have a superficial and deep infiltrate. You can tell that from this power. We don't know what the inflammatory cell components are. It's periadnexal, and that may or may not be helpful. So let's go and make sure that this is an interface dermatitis. So in order to do that, we're looking for necrotic keratinocytes. There's one there, there's one there. And of course, this also has vacuolar interface dermatitis with tons of holes, white spaces at the DEJ. All right, so let's look at the inflammatory component. And we see that there's lymphocytes, mostly, and extravasated erythrocytes. And let's look at the epidermis. We haven't talked about, we've talked a little bit about chronicity of cases, and we do have parakeratosis here. There's actually neutrophils in the horn. And so you guys should be familiar with a neutrophil in the horn differential diagnosis. So sometimes pulling, you think, okay, what are my findings? What algorithms do I have? And then a lot of times you can arrive at the diagnosis from multiple different algorithms. So this one's superficial and deep. It's more of a vacuolar interface dermatitis. There's extravasated erythrocytes, there's parakeratosis, there's neutrophils, there's extravasated erythrocytes. So this is Pityriasis lichenoides. It turns out it's more Mucke-Habermann, or the acute form, PLEVA. Of course, if we know it's from a child and see papulonecrotic lesions, then that sort of fits well with Mucke-Habermann disease. Of course, you know that there is a Pityriasis lichenoides et varioliformis acuta, and there's Pityriasis lichenoides chronica. Chronica should also be superficial and deep, but it has much more of a subtle infiltrate. With Mucke-Habermann or PLEVA, we have a much more intense inflammatory response. This also fits into the lichenoid, the psoriasiform lichenoid dermatitis, which I mentioned earlier, which would have PLEVA, Mycosis fungoides as part of that. In Gougeron bloom type. So again, this is Mucke-Habermann disease. A little bit of spiky, reedy ridges, so everything's not perfect. This is not syphilis. If you were worried, again, in the right clinical setting, you could get a treponemal stain or have the patient or ask the dermatologist to get an RPR. Okay, so let's move on to the next case. All right, so at low power, we see a more superficial perivascular infiltrate, maybe a little bit of follicular involvement. And again, sometimes you'll get a little bit of crossover of both superficial and deep. So let's go and look at the epidermis. All right, and we have necrotic keratinocytes. This one's more vacuolar alteration because we don't have a band-like infiltrate. The interesting thing about this case is that it has a more of an atrophic epidermis. And when there's atrophy of the epidermis, so as there's a psoriasiform lichenoid, there's more atrophic pattern. We think of things like connective tissue disease, and lichen planus can be atrophic, although usually lichen planus has a more dense band-like infiltrate. This is on more sun-damaged skin. You can tell now, while this slide is a little more washed out over time, it's probably a little bit older. It looks more, has more hematoxylin staining, but still you can see the fibers here. There's some solar elastosis, and it looks like there's some interstitial mucin. So there's spreading between the fibers, and mucin is a more granular material in between. So we have an atrophic vacuolar interface dermatitis with mostly lymphocytes. So again, it's all lymphocytes. Typically, when you have eosinophils, you don't want to think of connective tissue disease. And so we have in interface dermatitis with mucin. So this is either lupus or dermatomyositis. Since it's more superficial, it's probably more likely dermatomyositis. If we get a clinical photo, then again, in the right clinical scenario, this is more consistent with dermatomyositis. Okay, next case here. All right. So at low power, we see that this is a superficial and deep, but this is very deep with inflammation. It's into the subcutis. So here we have our subcuticular deep dermal junction. So here are the lobules of the subcutis. Okay, and Dirk Elston would use a term called towers of lymph. So big towers of lymphocytes, and that's often seen in lymphoma and the condition we're about to talk about. Superficial and deep perivascular periecrine, of course, that was seen in lichen striatus that we already talked about. But when we go focus on the epidermis, we see that there are numerous necrotic keratinocytes. Let's see, so there was one here. There's one here. So again, we're dealing with a interface dermatitis. This one's more vacuolar because we have the spaces at the DEJ. There's a follicular plug. There's pigmentary incontinence dropout. Look, we have the squamosization of the basal layer or the premature maturation of the basal layer. There's even a thickened basement membrane here that if you did a PAS stain, you could highlight that. So thickened basement membrane. We have hair follicle involvement. All right, so all of these features are consistent with discoid lupus erythematosus. Again, tower of lymphs, but typically in lymphoma, we're not going to see these type of epidermal changes. Now, dermatomyositis can look a lot like lupus, but normally it doesn't have the depth of the inflammation that lupus erythematosus has. One thing that's really not prominent in this case, here it is, an increase in interstitial mucin. So here you can see between these collagen bundles, we have an increase in mucin. So again, that's consistent with connective tissue disease. And the fact that there are no eosinophils, that this is all lymphocytes, again, is consistent with a connective tissue disease. Of course, if we have a clinical photo like this, it's pretty clear cut that it's lupus erythematosus. Okay, so next case. Here we have a shaved biopsy, and so again, we can't really assess whether or not this is superficial and deep. And so, you know, I try to do punch biopsies whenever I can for rashes. But a lot of times when we know they're spongiotic clinically, we don't tend to do it, but it helps knowing the superficial, that there's the superficial only component or superficial and deep component. All right, so let's go to higher power. All right, and so let's look at the epidermis and we see there's necrotic keratinocytes. So again, this is an interface dermatitis. This one's more bacchiolar than lichenoid because there isn't a band. We have pigmentary dropout, and the cells are mostly lymphocytes. Okay. One other thing to note is there's hair follicle involvement, and that can be seen often like in planopilaris. And look, there are eosinophils, and that's going to be an important point with this. So this patient is in a hematology ward, so again, clinical history is vital because with the interface dermatitis and eos, this could just be a lichenoid drug eruption. However, we have hair follicle involvement, and this is what the clinical presentation is of the patient. So this is graft versus host disease. All right, so let's just talk quickly about the different stages of graft versus host disease. There's actually 5 stages, stage 1 being 0. The problem is you can't really make a stage 0 diagnosis because there's no findings at all. Stage 1, we start to see the very beginnings of necrotic keratinocytes with very little inflammation. Stage 2 is normally when you make the diagnosis because there's inflammation and interface dermatitis, and that's the point when you can make the diagnosis. Stage 3, typically you have such significant interface dermatitis that the vacuoles expand and make vesicles at the DEJ, and you get more of a vesicular pattern. And then stage 4 is when you have full thickness necrosis like you would see in some forms of Stevens-Johnson syndrome and toxic epidermolytic necrolysis, TEN. It can look just like that, but this is a stage 2 graft versus host disease. One other thing to note about graft versus host disease is that it can be more of an acute interface dermatitis. This has a little more chronicity to it, so this may be more of a lichenoid, or the lichenoid variant, which looks more like lichen planus, although we don't have the band-like infiltrate. And then in some patients that have chronic graft versus host disease, they can develop a sclerodermoid component. So this is graft versus host disease. Okay, move on to the next case. Okay, go to lower power here, higher power, excuse me. All right, the pattern analysis, we see a superficial and deep perivascular infiltrate. And obviously at low power, we're noticing something's going on at the DJ. There's all these, there's this vesicle formation. And so sort of, one thing at low power you might be thinking about, well, is this a vesicular, immunobullous disorder like bullous pemphigoid? Of course, we have to know what the inflammatory component is. And when we look at the inflammatory component, we do have a mixture of lymphocytes and abundant eosinophils. There's a little bit of pigmentary incontinence. What I find I do when I have a vesicular dermatitis, I want to go to the edge where there isn't a vesicle, because I want to see what the true nature of this lesion is. And actually, if we look, there are abundant necrotic keratinocytes present and some vacuoles. So this is a more so this is an interface dermatitis and not a primary immunobullous eruption, because you wouldn't see necrotic keratinocytes in bullous pemphigoid, even though there are EOs. The other interesting thing about this is there is a basket weave orthokeratosis. So this came on very fast. This is acute. It was biopsied shortly after it occurred. And usually when I think of acute interface dermatitis, I think of fixed drug eruption and erythema multiforme. All right, but this has superficial and deep, and it's a mixed infiltrate with EOs and lymphocytes. And so this is fixed drug eruption. Of course, if we have this plaque on the back of a patient, then it becomes pretty clear cut that it's fixed drug eruption. But just on histopathology alone, you saw I had to run through the immunobullous differential to sort of work it out and try to figure out what it was. Of course, you can get fixed drug that's vesicular when you, and so sometimes it can be, you biopsy this in isolation, oh, this is TEN, but in the right clinical scenario, it's not TEN. Okay. All right, let's move on to the next case. Okay, so we have a superficial only infiltrate. The infiltrate is composed of mostly lymphocytes, a little bit of extravasated erythrocytes. There is some pigmentary incontinence. And now let's look at the epidermis. For necrotic keratinocytes, I see a lot of vacuoles, but I don't see many necrotic keratinocytes. I don't see any. And I see a lymph in many of the holes, and these lymphocytes are a bit enlarged. There's a basket weave orthokeratosis above this. Fairly normal epidermal thickness. Papillary dermis is a bit fibrotic. Okay, so with this type of case, you're sort of, well, is this Pityriasis lichenoides? I'm not seeing necrotic keratinocytes. Is this a drug eruption? I'm not seeing eosinophils. Boy, there's a lot of lymphocytes in the epidermis, and that can be seen often in spongiotic dermatitis because with spongiosis, you can get exocytosis of lymphocytes. However, there's not a lot of spongiosis here, and some of these lymphocytes are large and a bit hyperchromatic. So this actually turned out to be early patch stage Mycosis fungoides, and this is one of the more difficult diagnoses to make as a dermatopathologist. It's a mimicker of interface dermatitis, and one of the confusing things is even if I had found a couple necrotic keratinocytes, Lorenzo Troni out of Austria's paper showed that early patch stage Mycosis fungoides, 20% of cases have interface dermatitis. And so that's why a lot of times with the clinical presentation, sometimes these patients just get a diagnosis of chronic dermatitis that they smolder on for 20 years. We do immunos, sometimes we do gene rearrangement studies to try to figure this out. But this is early patch stage Mycosis fungoides. Okay, move to the next. All right, so this is a lot of our favorite one because it's probably the easiest on an exam to make a diagnosis of for interface dermatitis because it tends to be composed within 1 to 3 reedy ridges. You get a band-like infiltrate, so it's more lichenoid. There's really not even a lot of necrotic keratinocytes. It turns out in this case, this was scratched, so there's an excoriation up here. And the inflammation is a mixture of lymphocytes and histiocytes. Sometimes we call it the ball and claw. So this is lichen nitidus. Clinically, though, it can be difficult to differentiate between papular eczema in kids with atopic dermatitis. But here we have these little flat-topped 1 to 2 millimeter papules. And so, of course, if you get the clinical and the histopathology, it makes it much easier, but that was lichen nitidus. Okay. All right, so this slide's a little bit older, and it shows more eosins, a little bit more red and pink than some of the other slides. I'm gathering that it's a vacuolar interface dermatitis, superficial. There is a little bit of deep inflammation here, and so that should make us go to Bernie Ackerman's algorithm and look at the superficial and deep. We have necrotic keratinocytes, numerous necrotic keratinocytes, the vacuolar alteration. There's pigmentary incontinence. It is superficial and deep. Again, this is not very specific. I mentioned lichenoid drug eruption earlier, but just regular. There's so many different types of drug eruptions, as you know, clinically, and they all can have a component of interface dermatitis. So this should be a drug eruption itself. The other interesting thing about this is a basket weave orthokeratosis is superficial and deep with pigmentary incontinence. So is this a mild form of fixed drug eruption? Is this erythema multiforme that usually doesn't have superficial and deep? But it turns out that this was labeled as Pityriasis lichenoides chronica. This would be more hypopigmented patches and diffuse over the body, not papillonecrotics like you see in Mucha-Habermann's disease. But you can tell with this one, this is not specific. This would be a very difficult one to test. And oftentimes in real life, they don't read the book. They don't have a perfect pattern. But this was labeled Pityriasis lichenoides chronica. Okay. Okay, we're coming to the end here. Yeah, so let's find one that doesn't have a bubble on it. Okay, here we go. Yeah, this is formed by the cover slip lifting up and air getting under it, but it's sort of attaching to where the tissue is. So let's avoid that. Just for a little board tip on that, sometimes it happens and it makes sort of a brownish color when it goes over top, and that's called corn flaking. And that might be on the board exam as a possible artifact, because they like to ask artifacts. All right, so here we have superficial infiltrate. If we look, and I'm wondering if this slide's warped because I'm having a hard time. I don't know if you guys had a hard time getting it into focus. It's a mostly lymphocytic infiltrate, and there's numerous necrotic keratinocytes. Let me see if I can go to another one that we can actually get this in focus. Here we go. All right, so all lymphocytes, abundant necrotic keratinocytes, sometimes at all levels, forming spaces. Look, there's a acute horn or basket weed or orthokeratosis. Since it's superficial only, then this falls into the spectrum of erythema multiforme, Stevens-Johnson syndrome, and the very early form of toxic epidermolytic necrolysis. Now, it's important to note that when somebody does a biopsy, you really can't differentiate between those three conditions. There's a lot of clinical things that are helpful with that. Here's the clinical photo. So here we know it's erythema multiforme. Remember though that even urticarial multiforme can look like this clinic, and then you biopsy and it's superficial perivascular with eosinophils and no necrotic keratinocytes, and it's not EM, where this is EM. And so, you know, it's more of a clinical distinction of differentiating EM major from Stevens-Johnson, whether there's oral mucosal involvement, whether the patient has Nikolsky sign, do they have macules instead of papules? Usually if it's more papular, it's more likely EM major, or, actually this is the example of corn flaking right here that I was telling you about, these little black things because there's air under the slide there. Usually patients with TEN have a more macular eruption that then starts to shed. Okay, well, let me go back to the initial slide here to sort of wrap it up. I don't want to thank everybody for their attention today. I know it was sort of the same pattern over and over again, but I think it's important because tests of knowledge, they like to give you interface dermatitis, and you have to differentiate between those. And I think using this pattern analysis of lichenoid versus vacuolar, then breaking it down into its inflammatory component, and there's some other things I didn't talk about. You know, this goes into the ballooning we had talked about is sort of where you get the keratinocytes sort of stretch out around it. So there's no ballooning with this. There is ballooning with erythema multiforme. We sort of saw that, and let me just show you in that last photo. There was ballooning here, and that's important. You see these strands, that's ballooning. You can see that in viral infections like hand, foot, and mouth, and we didn't talk about that. Hand, foot, and mouth can look a lot like erythema multiforme. So again, review these 3 slides when you go back to study your boards, at least for the interface dermatitis. I want to thank you again. I want to thank again Dr. Davis for hosting the event or inviting me to talk, and look forward to seeing you guys again at another happy hour. Thank you very much.